Good afternoon, everybody. As you hear that it is the webinar series, the second in the series by Apne, Mental Health Webinar. It is today the title is Moral Injury, Emotional Exhaustion and Compassion Fatigue. It is important that healthcare professionals are able to emotionally deal with complexities of ethical decision-making and understanding, and the concept of moral injury and emotional exhaustion that could predispose them to developing stress-related conditions and compassion fatigue. This short talk this evening would cover lessons from key academic literature, field studies, and case examples, and signpost the audience to relevant resources for professional support and self-help. So before I go further to introduce the chair, I would let the audience know that please keep as the talk goes along, you can continue sending your questions. And also, if you're interested to get the source material sent over to you, you can kindly contact us at info@apne.uk. I repeat the email, info@apne.uk. Our session this afternoon, this evening is being shared by Dr. Iftikhar Ahmed, who is a graduate from Punjab University, Pakistan, and initial work in psychiatry in Pakistan. He moved to UK, where he completed basic and higher specialist training in psychiatry in Trent region. Dr. Iftikhar has worked as consultant adult psychiatrist since 1999, initially in Sheffield. And since 2004, he has been at Dudley and Walsall Mental Health Partnership Trust, and he has undertook responsibilities as clinical director for community and recovery services between the years of 2011 and 2018. And from May 2018 to February 2019 as a joint medical director. Dr. Iftikhar is a trainer for core psychiatric trainees and medical students. He have been an elected member of Executive Committee West Midland Division of the Royal College of Psychiatrists, and has been examiner for CASC and currently an assessor for Royal College of Psychiatrists. He is an active member of Mental Health Act approval panel for Midland and East of England. So without much ado, I feel pleasure handing over to Dr. Iftikhar.
Thank you, Dr. Iqbal Naeem, for this very kind introduction. It is my pleasure to introduce today's speaker, and is a really good friend, Professor Rafi Faruqi. Though most of the people know him, but it is my pleasure to introduce him as he's a professor of psychiatry at Kent University and Kent and Medway Partnership NHS Trust. He's an experienced psychiatrist and has a track record of his disaster management planning and workforce support. He has a particular clinical and academic interest in stress-related disorders, workforce training, and emotional aspects of caring in disaster zones. He is a former chair of neuropsychiatry faculty at the Royal College of Psychiatrists and co-editor of forthcoming Oxford textbook of neuropsychiatry. I will hand over to Professor Faruqi, just with one request that please all of the people who are attending this webinar, that please send your comments and questions so that we can respond to them towards the end of this presentation. So, Professor Faruqi.
Assalamu alaikum, Iftikhar, assalamu alaikum, everyone. Thank you for inviting me to give this webinar. Particularly thankful to all colleagues in Mental Health Task Force, Dr. Amir Barni, Dr. Shahid Latif, Dr. Hassan Javed in particular, for organizing this wonderful series of seminars. Title of my talk is Moral Injury, Emotional Exhaustion, and Compassion Fatigue. You all would have heard about stress-related conditions, post-traumatic stress disorder, acute stress reactions. It's important to understand these three terms in the context of disaster management, in the context of working in difficult life circumstances, and in the context of COVID-19.
Professor Farooqi, can you share the screen, please, of your slides?
Yes, I am going to share the screen when I start going through the slides. So the talk is about supporting healthcare, emergency, and community care workforce. You are the experts. You are the people who are looking after patients suffering with COVID-19. You are the people who are on the front line. So the talk is not about telling you what you are doing. The talk is about experience sharing. Allow some reflection on practice and things and emotions that go on in the frontline workforce's mind. I will briefly talk about concept of response preparedness and how to promote adaptive coping. And in particular, as a group, we would encourage you to be kind to each other, to look after your colleagues, to look after your families, and encourage what we call in emergency and disaster management language, encourage peer support. That is so essential in going through difficult periods in life and history. So webinar structure. So I will clarify some key terminology, so definitions. They could be boring, but they are still important to clarify certain concepts. I will bring in examples from fieldwork. I will briefly talk about history of epidemics and pandemics in a way to remind you that these are part of human history. These are part of our existence. They will go, but they will come back. I will talk about epidemics in film, literature, and art. And I will share some painting slides that have been offered for presentation by my dear friend and colleague, Syed Ali Wasif, who's a psychiatrist in Pakistan and a famous artist. I will talk about workforce stress in disaster place. I will talk about what can you do in these circumstances, and I will end my presentation by introducing the concept of what we call post-traumatic growth. So, moral injury. We all go through ethical dilemmas when we are seeing our patients or caring for people who are in need. Ethical dilemmas lead to moral questions. It leads to people questioning themselves. Are they providing the right quality of care? Are they serving the person they are treating? Are they harming people? Are they able to protect the needy and the vulnerable? So individuals who are exposed to traumatic events that violate their moral values may experience severe distress and functional impairment known as moral injury. That is one definition. There are other definitions, but I think this describes this emotional process quite well. If you go through literature on moral injury, you will see that an association with post-traumatic stress disorder has been described. But these two phenomena are described as separate constructs. What sometimes combine them is depressed mood. And I will talk about why it is important to be able to support colleagues and identify the people who are in more vulnerable areas in their life. So that is the artist's depiction of moral injury and having to deal with ethical dilemmas. So emotional exhaustion. The disadvantage of webinars is that I'm unable to ask the participants to share their experience of emotional exhaustion. directly. They may wish to share through their questions. But emotional exhaustion and emotional dissonance are well described in workplace literature on burnout. Ethical dilemmas and moral injury contribute to emotional dissonance and may lead to emotional exhaustion. Medical literature suggests that perceived quality of care negatively related to emotional exhaustion. Our experience of working in disaster zone is that emotional exhaustion presents a little bit differently. Recognition of emotional exhaustion is important. You need to suspect it when a team member tells you that they feel drained, but still want to do more, but at the same time feel unable to face the day. It's a position of exhaustion and being ambivalent. In disaster zone, it does carry burnout and suicide risk. Very important for supporting work teams who are looking after people in difficult zones. This again, kindly shared by Sayyid Ali Wasif.
Please share the presentation.
Sorry, Iftikhar?
Please share the presentation. It's not on the screen.
Are you not able to see it?
No. Just.
Amir, are you able to help?
Okay, if you go and click on the green button on the screen, top share screen.
Yeah. Share contents.
No, I've gone through the share content.
Just should be able to say share screen. Just click on the button saying share screen.
So now if you share that again.
You should be able to share it. We have given you access. Can you try sharing, please?
When you click share screen button, a drop-down list appears.
Are you able to see it now?
Yeah,
Yes.
that's great. Yeah.
Okay.
That's fine now. Thank you.
Fantastic. Yeah.
Could you go into presentation mode, please?
Thanks, Rafi.
So this is where I was. So artist's description of emotional exhaustion. So moving on with my talk. So compassion fatigue. So in medical literature, compassion fatigue has been described as a convergence of what people describe as secondary traumatic stress and cumulative burnout. It's a state of physical and mental exhaustion caused by a depleted ability to cope with one's everyday environment. It drains the will to look after people out of very good professionals. You have to work in difficult areas to recognize that it does happen. No one is invincible. It can happen to best of the people. An artist describe it as then you are lonely, sitting on your own, and of course, resorting to red wine or something. So if I give you some examples from field work. So a doctor who once told me that his team had to amputate a survivor's limb to get her out of rubble, basically after an earthquake. The doctor was traumatized that their decision to amputate the limb was obviously to save girl's life, but was also intended to save the team because the earth was shaking. So those of you who have worked in earthquake areas, you know, it's not that a big earthquake comes and goes. Then you have multiple aftershocks. They are life-threatening, And sometime even aftershocks are over 4 or 4+ magnitude. They are mini earthquakes. Then another example, when a colleague of mine wanted to report somebody to the police. It was when we were working in a remote area of Punjab after religious riots. And not only that, we met people who were affected or victims, we ended up meeting people who probably were perpetrators. So it is moral injury when a human rights worker or a medical worker would want to report somebody, but because of medical confidentiality and other aspects related to disaster management work are unable to do that. And then recently a colleague telling me that in the context of COVID-19, if you were not young, fit, and healthy, you may not get a ventilator. I think healthcare has gone through a very difficult period that has challenges our moral and ethical values, that has challenged our resources, that has challenged our managers in providing a good service. So moving on from here and now to a brief history of epidemics. I did say earlier on in my talk that epidemics, they come and they go. And some of the epidemics have practically vanished. So smallpox is probably one of the examples. Probably the most devastating of human diseases, if you look at the history of medicine and epidemics. It spread in populations, thousands of years, spread across regions through trade, war, and migration. And I think these kind of key routes to spread of an epidemic becoming a pandemic. It is said that it either originated in Indus Valley or Egypt, or relatively more recently in Horn of Africa, which is the old kingdom of Queen Sheba. And again, like COVID-19, there was evidence of animal to human transmission, possibly through domesticated camels. It was officially declared eradicated in 1979 following successful vaccination program. I think it's a message of hope. Plague. We have read stories about plague in India. We have read stories about plague in London. We have read stories of plague devastating areas of Middle East and Iran. We know that earlier on, a role of rats and fleas was identified in transmission. So there are ways of studying and managing and reducing the spread of these pandemics. And we know 3 huge pandemics since the 6th century BC has caused millions of deaths. And of course, numerous smaller pandemics. I think more recently, a lot of colleagues have talked to me about Spanish flu. It spread across Europe, Northern America, and Asia over a 12-month period. 500 million infections, that is the estimate, and about 50 to 100 million deaths worldwide, coming in 2 waves. Now thinking about COVID-19, it is coming under control in some parts of the world, not all. Overall, it is spreading. And we know as we are entering into winter soon, there is a risk of a second wave, magnified, of course, by our need to be able to run our businesses, our trade, and our lives in near normal way as possible. But looking at the history of influenza pandemic, so Spanish flu is not the only one. There have been 5 in the last kind of 102 years or so. So some of you, I did talk about best of the best being affected by what happens in the disaster zones and what happens when they are caring for people at very difficult times. Depiction of those difficulties is Ben Kingsley's The Physician. You can find it on Netflix, portraying a famous physician from Muslim history and showing him committing suicide around a time when there was a plague epidemic in the area. No causal relationship has been explained, but it just signifies how physician, the eminence of that physician, and an epidemic has been portrayed in film. Then Chair Dr. Iftikhar reminded me of Rajinder Singh's Bedi's Karantina, and character of Bhog, who was battling with the ethical issues related to care of people who were put in quarantine in undivided India. And then I have already shared with you Syed Ali Wasif's work. And there is more, what we call art during COVID-19. I think the art during COVID-19 will make history, and we will continue to see it in different shapes and forms over next many years. So now a brief review of workforce distress and medical literature. I don't want to make this webinar into an academic or a purely academic presentation, but it is important to look at what has been researched in order to understand if there are key lessons in terms of care and looking after ourselves. So this is amongst the very early studies from China, a very high response rate. So 1,257 people responded out of 1,830. 50% reported depression, 44% anxiety, high report of insomnia, but distress was reported by almost 71.5% of people. Nurses, female colleagues, frontline workers, and those working in Wuhan reported more severe symptoms. So if you link it with, for example, disaster literature from earthquake areas, so workers who are working close to epicenter, okay, or man-made disasters, workers who are working close to the bomb blast area, they are likely to be more affected. And I think that is a lesson in terms of looking after people. So how do we cope? And I think a good example is if we look at literature from Ebola. That's a relatively recent epidemic. It's still there in some parts of the world. So coping strategies that people use, they draw upon existing mechanisms. So being sustained by religion, a sense of serving their country and community. And I think we all probably could reflect on these 2 points. And of course, peer and family support. But there are also what we call externally derived strategies, okay? And that is important for disaster preparedness or preparing our workforce to be able to continue to do an excellent job at difficult times at different points in history. So training to build healthcare workers' confidence in providing care at difficult times, in disaster zones, in pandemics. Provision of equipment to do their job safely. If I ask you how many had access to safe and sound PPE at the beginning of pandemic, I think probably you know the answer. But then what colleagues from Ebola work report that having a social media platform to exchange views and distress and communicate was immensely helpful. And then, of course, training workshops to deal with the stigma of working with a deadly disease. And most importantly, a risk allowance. Okay, so I think there are lessons for our NHS, our employer, and there are lessons for us and our wider teams, and things that could be done. So again, talking about workforce preparedness against disaster and emotional trauma. So there is a very good review. I was looking at literature, and I thought they had described or divided the key lessons in a very nice way. So what predisposes or protect people against stress? So specialized training protects, preparedness protects, and health, if they have had health events prior to disaster, that doesn't. If they are in good health, it protects. And if there are difficult life events in pre-disaster periods, then that probably is a risk factor for high levels of stress. The disaster factors, exposure, I think we have talked about being at the epicenter. So duration on site, arrival time, the frontline workers I have talked to over the years, I have talked to people who have worked through without any break for days. Okay. So it's not that they were emotionally exhausted, they were physically exhausted. Okay. But they were still motivated, they still wanted to save lives, but it does have a cost. Then there is a concept of peri-traumatic distress. Distress is the people who dissociate a little bit, who lose awareness of what is happening. Okay, it's a risk factor for developing post-traumatic stress disorder. And it's important to identify these people having these experiences early so that the appropriate strategies to support them could be put in place. Role-related distress, perceptions of safety, threat, and risk. And then, of course, people who get injured themselves. So the workers in disaster zones or looking after COVID who develop COVID themselves, I think we will know over a period of time that whether their rates of being affected emotionally higher in comparison to other people. So again, social support and professional support does count, but there are post-disaster factors. Professional support again is important. Impact on life. If someone loses a partner or a child or a close family members, its impact on life, it sometimes does define how they are going to present emotionally after a disaster. And again, new life events, what is happening in media and coping strategies. Interestingly, there was one report saying that if you are watching media, don't watch it for more than 4 hours. Okay, it doesn't help with your emotional well-being if you are looking at disaster news and related programs. So what are the key messages? So key messages, please look after everyone. And in particular, look after volunteers, okay? So professional workers and professional rescue workers, they generally do better, okay? Because there are organizational structures, there is training, and there are support system in place. Volunteers, the same level of preparedness and same level of safety and precautions, and the aftercare is usually not there. So you have to look after them more. Okay, but more interestingly, in COVID time, how many of us have performed duties that we were not performing before? I'm sure there were many. So those performing duties they have not performed before are at risk. Okay, it is about role ambiguity, not knowing, working outside some time of our expertise area. And if that is happening, that is where you are more likely to be affected emotionally, and the questions around moral injury and emotional exhaustion and compassion fatigue become more prominent. And those experiencing injury or near-death experience and perceived risk and lack of safety, we know that's significantly associated with poor outcome. A lot of us were concerned about PPE in the beginning. And I think we will find out about the long-term impact of our experience as a community of practice and how it will affect professional emotional well-being over a period of time. And of course, look after colleagues. with changes to life and personal circumstances. People who leave, who lose their employment, for example, and who incur property loss or financial loss. I think the message is that it is important that we invest into skills development. What organizations are able to do, I think they can do a lot. I have to say the organization I'm working with, I think they are doing decently, and I'm sure some other organizations are. So training in peer support, workshops encouraging coping strategies such as mindfulness, problem solving, education about stress, training in relaxation techniques, coping skills program, and reflective practice group. I think what Apne is doing is the same. So offering webinars, and that's the educational purpose. Then I was asked by Dr. Hassan Javed to request a colleague to prepare a set of materials people can use for self-help. So that is there. And we are working towards developing reflective practice group. And this is the artist's depiction of people coming together and families coming together. So almost finishing my talk. So I did say that I will close after talking about post-traumatic growth. So what a philosopher says is that what doesn't kill you makes you stronger. So the message, or the whole message, is not about despair. So it's important that we understand that sometimes disasters and pandemics and difficult times in life actually makes us stronger. They make us think about changing priorities. They make us think about more meaningful interpersonal relationships. And they make us have a different and a wider appreciation for life in general. So in summary, we have talked about moral injury. We have talked about emotional exhaustion, compassion fatigue, and talking about these three concepts has allowed us to explore issues related to traumatic stress in the workforce. We have reviewed a brief history of epidemics to set the context in terms of recurring nature of these life-changing experiences. As human beings, we are not invincible. It is important that we look after our colleagues, our communities, families, and our own health. So use your leave allowance well. Take appropriate rest periods. Eat healthy. Exercise. Spend time with family. And give yourself some time. Explore your spirituality. Thank you.
Thank you, Rafi. This is in half an hour. It is such a right. You have just put so many things together, and very difficult topics of moral injury and PTSD and compassion fatigue you have brought together, and then gone through the history of the pandemics and coming up with some solutions. We are having a few questions, but taking the opportunity as being chair, can I just ask two aspects, one comment and the question is, just about the moral injury and the PTSD. I'm trying to clarify in my own head that the main difference between them, one can have, I will give an example, have a road traffic accident, which has not much moral impact as compared to abuse. Or, for example, you have described a few situations where health professionals had to make very difficult situations. There's a literature that they have the same impact later on in the development of symptomatology, if not careful.
Okay, so I think first talking about research methods, because you've talked about what happens to people. Okay, I don't think I have seen enough longitudinal study to kind of answer your questions
Mm.
in a research sense. But if you look at academic data on studies on armed forces,
Yeah.
okay, forces who are deployed in combat zones,
Yeah.
or deployed in relation to the internal aspects of security and care inside their
The
own
country.
countries. Okay, they are the other group that sometimes are exposed to moral injury.
Yes, I can.
Okay, of course they arrest people, they enforce law, they fight. Okay, and of course they go through difficult situations. So if you look at that population as a whole, not as individuals, but if you look at that population, then you see also literature of PTSD.
Okay.
Okay, but the moral injury and PTSD in the literature have been described as separate construct.
Okay.
Okay, what sometimes link them if the person is also depressed.
Mm.
Then you will see a person with PTSD also being depressed, but when you go through their history, then you will see the onset of events, and they will talk about their emotional journey of trauma and their experience of receiving care or not receiving care, or how the organization then dealt with them subsequently.
Thank you. Thank you. And just one more question before I open and I bring more, because of questions are flowing in. In the coping skills, you have mentioned about mindfulness and quite a few other coping skills. What about, we usually forget, and especially health professionals, about kindness to oneself. And you have described really good example of this emotional exhaustion, where you can see the person who still wants to continue working, though they are sharing their physical symptomatology, if I use the word condition. We usually are very hard, health professionals or people who are into this, to themselves. They can help others, but they don't give any, if I say, space to themselves. It is a concept of personal kindness to oneself.
Well, I think it's a pertinent point, Iftikhar. I think my experience working in different kind of field zones or in my clinical practice, yes, we need to be generous with each other. Okay, and yes, we should be able to be kind to ourselves and our families. Where skills development is still important, that there are times when even a kind and generous person
Yes.
is unable to contain their own emotions.
Yes.
And it is important then we encourage them to learn skills to control emotions so that they can re-experience their kindness.
Yes, thank you. And there are quite a few questions.
There are a few questions, Professor Farooqi, if I can. We have a question. Somebody didn't mention their name. It's anonymous, but I just put it through to you to respond. As a healthcare professional, how does one overcome fear and anxiety, especially in regards to risk of exposing family members?
Okay, so now let me put it straight. Okay, so fear or anxiety is not necessarily pathological in all circumstances. Okay, we have to be safe for ourselves and safe for our family. So
okay,
if you're not using appropriate PPE, then I think that needs to stop. Okay, if you are not taking appropriate precautions when you return home and wash your hands regularly, then that needs to change. Okay, but if you are doing everything right and you are still feeling anxious, okay, you are still feeling fearful, and that's affecting your relationship or that's affecting your quality of life, you are unable to sleep, then it is a problem. So first thing that is important is to understand what is the fear or anxiety that is realistic. COVID-19 is a life-threatening condition, okay? And it is important to keep that in the context. But when it becomes problematic and unrealistic, that is where you need self-help skills, you need supportive groups, and you need to know that if it starts to affect your quality of life and your well-being to the extent that you are living a miserable life, then you need to get help.
Okay, good. I hope this explains to our audience, and especially the person who asked this. And I have got another question. It's again anonymous. The person didn't put their name. The question says, as a healthcare professional, I am finding it very difficult to switch off work. Any advice?
Okay, if you look at use of mindfulness in healthcare professionals, okay, it's a good technique. You need to learn and practice it. It's one way of switching off. Of course, it's not the only way of switching off, but it's worth checking out, and it's worth practicing. There are good books available. I believe that there are YouTubes available. I have not seen any myself, but I've been told. So there is a lot of literature that is available on mindfulness, and I think that is what I would recommend. But that is the simple answer. But then there are degrees of difficulties. I think the question is, are you able to give sufficient time to your children, for example? What about giving a little bit of time to your mother or your wife? Okay. What about picking up telephone and calling a long lost friend who is been unwell? What about the money you are not spending because you are not going out that much and engaging in some charity work? Okay. And all this contributes to your emotional well-being.
Sure, thank you. And also, I would like to read this, our friend Dr. Shahab Qureshi is mentioning, asylum seekers, another group undergoing moral injury. Of course, Dr. Qureshi, that's right, but I think asylum is another source of stress and other complication, but our topic is slightly different today. But I do appreciate, thank you for your contribution.
So if I make a point here, Iqbal bhai, a group of colleagues I'm working with, I've never met them. It's an academic group. Okay, they are working in Bangladesh. Okay, they are working with asylum seekers from Rohingya community.
Right.
Okay, and of course there are concerns that their existence difficulties is making it difficult to manage the spread of virus, for example, and manage their distress and manage their life and livelihood at these difficult times. So yes, there are areas in the world where it is kind of very important. And I'm sure it's even a challenge for asylum seeker community here in UK. So, for example, I know, I live in a small city. We have only one mosque, for example. Okay, so people know each other. So we know there are people who are trying to look after asylum seeking community a little bit more than they usually do, because they know that they are more vulnerable at these difficult times. Sorry, I interrupted.
Can I ask a few questions? Because there are a few questions coming up on my screen. Just one aspect is, during this pandemic, a lot of people are working from home, which is quite a big change in their routine. And also at the same time worried about the outside world, but how do we manage that aspect and becoming anxious and having this guilt feeling that I'm not out there, I'm not going sometime, finding a balance between them? Any advice?
Well, in a way, I think sometimes I draw my response to what we call a certain professional framework. Okay, so a behaviorist approach is that you work on structuring your day or daily routine. Okay, because if you are sitting at home and seeing your people from your dining table and offering webinars sitting on your dining table and eating on your dining table, and having a chat with your children on a dining table, life becomes very, very difficult. So unless you have a structure in your day, or you try to bring one, you can't break the monotony of your existence. So please find time again for your family. Even if you don't like a TV program, maybe you can watch it with one of your child. Go out for a walk. If you are a religious person, then maybe try to offer prayers in a Jamaat, for example, at your house. Nobody is stopping you from doing that. So I think the appropriate or one appropriate response is structuring your day.
Thank you. Just one more. There's some question somebody has asked, and I'm taking the opportunity of you being here in the webinar. It's not directly related, but it is related to COVID-19. And what do you expect from the mental health problems emerging through this pandemic as we move forward? There are a few studies coming up, and if you could just share with us some your.
Okay, so you have to look at in different layers. Of course, what we are dealing with today is supporting emotional health of our colleagues or healthcare professionals or community care workers or emergency care. So it's a more defined group.
Yeah.
But then there is a group we call wider population.
Yes.
Okay. So the spread of different problems would be a little bit different in the general population. Okay. So it's important to understand some basic principles of epidemiology. So certain problems would be more paramount or prominent in one particular group. So similarly, if we move up to people who were affected more from COVID-19 and required admissions in hospital settings,
yes,
then we probably will, Iftikhar, you know that we are learning about higher rates of strokes, for example. Yes. We are learning about pulmonary embolisms. We are learning about the neurocognitive effects. Okay? Yeah. We are learning about very severe post-ITU syndrome. We are learning about severe agitation and complex neuropsychiatric conditions. Not everyone, but so, and we are learning at the same time the emotional aspects of becoming very, very ill with a life-threatening illness like post-traumatic stress disorder. And I think kind of that's a particular population frame that requires care or extra care in the community in its own right. Now, if we go to, so in a way, I have probably tackled a question slightly about the healthcare and community care and frontline, and I've tackled the question about the more ill population. I think let me talk about the general populations. Even in general population, okay, then there are different strata. So I'm working with my colleagues in Kent, for example. We want to study fear and stress in BAME population, okay? Because we think that understanding their fear and stress and be able to understand how it is different or similar to BAME population from the non-BAME population may have clues for how we construct public health messages for these people. But we know that people are presenting with fear, people are presenting with anxiety. We have just submitted a paper again with my colleagues in Bangladesh about fear and anxiety in a big population sample. So we know that there is a very prominent mental health need that is going and to emerge and emerging. So we need probably a public health response. If the sorry, not a easy answer.
No, I agree with you. And I was just, while we were talking, I was thinking of, we know that post 1957, this influenza thing, and pandemic at that time, especially with the mental health aspect and people who are presenting with affective components, and I was reading quite a few just case notes about how resistant the depression was. And keeping in mind it's a viral infection, and we know in post-viral infections, the mood dips and the incidence of depression is there. So that aspect is also, I think we need to cater our services to look at that aspect.
Yeah, absolutely, absolutely, and I think that's us acting as learning individuals.
Yeah.
So continuing to learn our health population needs, and continuing to learn needs of our patients.
And it is a process. It is a continuous.
It's a continuous process.
Yeah. But thank you very much. I will hand over to my colleague, Dr. Naeem Iqbal, for closing sentence.
I think one more question finally. I think you already touched this, Professor Farooqi, about mindfulness. So there is a question that impact of, in your view, impact of meditation and mindfulness on mental well-being. So maybe you can comment briefly on it before we close, please.
So I think if you look at meditation is a slightly different construct. Okay, so kind of offering ritualized religious activity, this is a separate construct. Mindfulness is a different construct. Okay, the first person who told me in detail about mindfulness is a senior friend, a reverend, kind of what you call is a priest. Okay, he was also trained in art of psychotherapy. Okay, and he used to teach mindfulness. So they're different constructs. So evidence in the literature would be different. Okay, but mindfulness does help with emotions management, does help with anxiety management. It does improve. There is some evidence in the context of stress. It does improve resilience. Okay, so that's your ability to deal with the stressful life situations and stressful life circumstances. And same could be said about meditation or religious activities. So if someone is coming to my clinic, for example, okay, and they have a particular preference, I actually go with their preference. Because some people, their spirituality is, for example, with namaz, okay, or roza. Some people, they don't feel that they are that religious, or they don't believe in the those spiritual aspects of some of the prayers. They want to do meditation. That's absolutely fine. What works for them. Mindfulness has become more of a scientific discipline now, because then there is more of research evidence and mindfulness used as a intervention by healthcare professionals. So my colleague Alan Dunlop, who kindly put the resource pack together, he's the expert, but he's becoming even a bigger expert. He's studying mindfulness again. So that's becoming a more of a scientific discipline. So you will see a different type of evidence set for different types of interventions, you can call, or preferred activities, you could call.
Thank you. Thank you. Thank you, everybody. Thank you, Professor Farooqi, and most of all the viewers, participants for their questions. I hope you have found the talk informative as I did. The topic, of course, moral injury, emotional exhaustion, and compassion fatigue has been very nicely and clearly explained by Professor Farooqi. It was indeed illuminating talk. And I think what I amused, that depiction of the topic through artwork, that has been really helpful. And we all know that the concept of this COVID-19 is absolutely unprecedented. So we have to look on all the aspects, and still the more you think it is inclusive, it is affecting our life, not the world globally, but our life in a 360-degree way, if you see. Family lives, personal life, professional lives. So what we need in this situation, first of all, to identify that everybody around us, the professionals, healthcare professionals, our colleagues, volunteers, other professionals, everybody needs support, not excluding ourselves, we as doctors, we are trained to feel and to act in a very resilient way, no doubt. But that doesn't mean that we cannot be stressed. So this is the right talk to focus, first of all, to identify that there are ways, whether reasons for us to identify and to act, not to go into burnout, to be able to help others. We need to clearly help ourselves. And Professor Farooqi rightly said to have sort of coping strategies, more general and specific reflection on day-to-day activities and our professional responsibilities, seek family and peer support. Okay, so these are the things which we know that even first of all, the reflection before and after all the time, it is important as first reflections to identify and really to acknowledge the difficulties, and then to be able to seek support, approaching others, colleagues, and the professionals. I'm sure the people who are in the audience, they're not everybody psychiatrists working in mental health. They can approach through their service. Again, very interesting factor was raised about social media, that spending too much time on social media or general media, you might be exposed to depressing news. But there is also a point that sometimes the misleading news, if you go on more social media, there is one kind of study showing up to 80% news might be either fake or misleading. So spend limited time on the right sites of social media. Also seek support through being with the family, resorting to your normal activities, hobbies in your breaks. Always be mindful of your regular sleep pattern, eating pattern. I'm sure in the subsequent series of these webinars, there is a talk on sleep as well, but here on today's, it is sometimes it can be early warning sign that we're going through stress, and it is also important to keep an eye on that. The people who are religious, for example, they can find relief and solace in their religious activities, and you can have more time to reflect, as we call in Urdu or Arabic, the khushu or khuzu. You can concentrate more, and then can be very rewarding. We talked about mindfulness, meditation can be the types of relaxation at the same time, having more understanding about the problems. They can be healing processes and the other types of activities. So with these closing words, I feel pleasure to thank enormously, first of all, to Apne and to our learned speaker this evening. And I have to remind yourselves, people who are interested to have this material, resource material, or even the presentation, they can email us at info@apne.uk. So if you send an email, we'll try our best to respond as soon as we can, and then material can be shared with you. And keep sending your suggestions, generally, any to improve us, and your feedback. And again, thank you very much. Have a very good evening. Any remarks by the chair or?
Oh, thank you very much for this. The only thing I will remind that Professor Farooqi has prepared very kindly a resource pack, and please send the email on info@apne.uk, and you can have that source pack, which is very, very helpful, explaining a lot of things and practical steps. Thank you.
Thank you.
Thank you very much, everybody, for joining the webinar today. As always, fantastic, Professor Farooqi. A very difficult topic, very challenging, and as highlighted by Dr. Iftikhar and Dr. Iqbal Naeem, not an easy one. Some of the comments that we've got back actually have said exactly the same, so it's not an easy topic, but it's been very positive, and I think I've learned a lot, so I'm sure the others have as well. So thank you to everyone for joining the Apne Web Mental Health Task Force webinar, and we look forward to seeing you again next Wednesday at the same time. Take care and assalamu alaikum.